The wide-angle viewing system and endoillummination is not only about the panoramic view that we get, but it's also improved the safety and efficacy of the surgery. And this is by reaching the peripheral retina without excessive rotation, allowing safe use of fragile small gauge instruments, and makes the bimanual surgery easier when we use the chandelier lights. The wide-angle viewing system, whether contact or non-contact, all depends on the indirect ophthalmoscope principle, where we have a high refractive lens below the microscope. This high refractive lens will produce an indirect or inverted image, which will need an inverter to make it an upright image. All types of wide-angle viewing system, whether contact or non-contact, will use this high refractive lens and will have an inverter. This high refractive lens could be contact or non-contact. We'll start with the contact lenses. And the main principle of the contact lenses is that it has a contact with the cornea coupled with a viscoelastic, and this will abolish the corneal aberrations. Abolishing the corneal aberrations will produce a better resolution, and this better resolution is for the same size visual field. The drawbacks of the contact lenses is that it needs an assistant, as we see in the photograph. Incomplete attachment during rotation will reduce the visibility. Also, it has a fixed field of view. When we have the non-contact types, you can change the distance between the contact and the cornea, and this will change the field of view. Many commercial types are available, and when we buy one, we should make sure that we take care of the trade-off between the resolution and the field of view. The higher resolution, the smaller the field of view, and vice versa. And that's why these type of lenses are best used for macular surgery. When we talk about vitrectomy contact lenses, we have to remember there is other types of vitrectomy contact lenses which were called the landers, and we used to use them like 25 years ago. And they're completely different from the wide-angle viewing system. They are formed of one component compared to the wide-angle viewing system, where they have two components and an air bubble in between. The landers will produce a virtual erect image with a limited view. The wide-angle viewing system will produce a real inverted image with a wide field of view. The non-contact types of lenses, they have excellent field of view up to 130 degrees, and they have an adjustable field compared to the fixed field of view for the contact lenses. By changing the distance between the lens and the cornea, we can change the field of view. And of course, the best thing about them is that they don't need any assistant. The disadvantage of the non-contact system is that they produce lens condensation, which could be reduced by draping or cooling the room temperature, and they also we can have corneal dehydration during the surgery, which could be compensated by the viscoelastics. There are 5 types of commercial non-contact systems: the Biome from Oculus, Recite from Zeiss, the Ibis from Hackstride, and the Opsis from Merlin, and the Payman lenses. Payman lender lenses. The widely available types in the market are the Biome, which can work with all microscope, and the Recite, which only work with the Zeiss. Both types could be having the focus changed manually or motorized with the foot switch. And both types have a wide field lenses and a macular system, and a macular lens. The Ibis, the Hackstride, which was the first type of non-contact lenses introduced in Egypt like 25 years ago, they only work with the Leica microscope. And the problem with them is they have the inverter built in the lower part, which makes the field of, they reduce the field of surgical field, which is very difficult to use. I'm not sure if they are still available in any hospital in Egypt. The Payman lenses, they are the first type of wide-angle viewing system to be introduced. It really produces a huge panoramic view, but the lens itself is fixed to the operating bed, which makes it difficult during adjustment. You have to adjust the microscope and the lens and the eye all on the same axis. It's very difficult. Now they have it fixed to the microscope, but still very huge and bulgy and difficult to use. As for the endoillummination, we should concern about 2 things: the field and the intensity. Most endoillummination now have a field of view angle more than 100 degrees. It doesn't make any sense to have a wide field of view by the lenses and have a limited illumination field. The intensity is very important. When we were introduced with the small gauge vitrectomy probes, we used to use the halogen illumination with the 20 gauge. Like when we entered with the 23 and the 25, these halogen sources were not enough to illuminate the retina. And then the xenon light sources were introduced. Originally, they were introduced as a separate sources from photon, actors, and bright star, and now they are built in the machines. It's very important to remember the phototoxicity of this illumination. We have to, this is a documented pathology that happens during vitrectomy, and to reduce the phototoxicity, we have to keep the endoillumination away from the retina at least 10 millimeters. And to do that, you should keep the illuminated area less than the 2 temporal arcades. If you found your illuminated area on the retina smaller than the 2 temporal arcades, you should pull the endoilluminated probe away from the retina. The other thing, you have to have a blue filter to cut off the harmful blue and ultraviolet rays, and very, very cautious use during the dye use, because the illumination interact with the light and produce free radicals. The last thing is the chandelier endoillumination. They are self-retained. They come in single fiber or dual fibers. It comes in the 23 gauge, 25, and 27, and 29. They should be introduced perpendicular rather than the oblique insertion as the other trocars, and these should be directed to the posterior pole. We can exchange them with the other probes. The benefit of the chandelier is you have a free hand. You can use it for bimanual surgery and self-scalar indentation, and we can also use it during chandelier-assisted serial blockade surgery, which allows the surgeon to sit on the microscope and have a wider view. Thank you very much.